I'm so excited. I got a chance to go through the lab and actually touch a piece of Gore-Tex, which my son has Gore-Tex in his body. And I got a chance to see how the valves are actually put inside the heart in the catheter, with the catheter.
Well, I was really interested in the cath demonstration because we actually got to put the guide wire in and to actually see what it really looks like was pretty amazing.
Most people love seeing and feeling and knowing what's going inside their body. They want to keep abreast of the technology. It's almost like watching Star Trek in front of them and seeing what's going to happen now, 5 years from now, 10 years from now, 50 years from now, perhaps.
One, I think it's really, really helpful to get to see all of the industry partners. They get to ask the questions from the companies and not just the doctors, you know, and get to see all of the stuff and touch it and feel it and play with it. And when you can, you know, really put your hands on it, it puts it in a different perspective.
You get a chance to see state-of-the-art technology that is being used. You get to hear from the best of the best doctors. I mean, they even fly doctors in from all over so they can come and share information with the parents and with other professionals.
It's a great opportunity for young trainees like me to interact with world-renowned experts. These kinds of events promotes awareness to learn and understand the physiology better.
You know, we're not exposed to congenital heart disease in our everyday training and practice, so it's really nice actually have a hands-on experience on the cutting edge technology.
For physicians to have a better understanding of the disease process, then they're more likely to know what the issues are, and also they will be more likely to channel them to the appropriate providers who can provide them the appropriate care. And for family members and patients themselves, this is such a great way to obtain social support, so they feel like they're not alone in what they're dealing with.
And I tell my friends what Alex has gone through or what he may face in the future or what it's meant to us, and they sympathize, but they can't really relate. And so one of the reasons to come here is the invaluable face-to-face time you get with others who've been through the same experience.
Hello, my name is Alan Lumsden. I'm the chairman of the Department of Cardiovascular Surgery here at Houston Methodist Hospital.
And I'm Zvonimir Krazier, current president of the International Society of Endovascular Specialists. We are excited to invite you to join us for our first annual IS-EVS Symposium. This premier conference will take place at the Houston Methodist Research Institute in the Texas Medical Center.
This is a 2.5-day conference, and it will offer didactic lectures from well-renowned cardiovascular interventionalists. It will also feature intensive hands-on workshops designed to teach interventionalists a variety of techniques. We plan to offer 3 tracks, one for the novice, or the new young surgeon or young interventionalist, an intermediate track, and an advanced track. That means you can hone your skills at an individualized level. By the end of the conference, attendees should be ready to apply these techniques and improve their clinical practice.
We hope you will join us, and we look forward to seeing you in September.
Bootcamp is a unique concept in that we are teaching in a multidisciplinary approach. Cardiologists, cardiac surgeons, vascular surgeons, CV anesthesiologists, and most of these are entry-level fellows. Well, that means they're already trained in medicine or something general surgery, but it's their first month into cardiovascular training. And so we want to teach them the basics, we want to teach it broadly, and we want to teach it early.
think it's grown significantly in the last year even. They've added some new stations this year. One important one for us, for the cardiac anesthesiologist, is troubleshooting on cardiopulmonary bypass, which would be very helpful. Hopefully we'll experience some things that we may see in the operating room and know how to troubleshoot them because of this.
Just getting to have a really real-life simulated experience that's really hard to obtain when you're actually in the lab with a patient. It's been a really nice experience to be able to do this in a controlled setting.
The faculty seem very interested in promoting intellectual curiosity, and they seem very motivated in teaching in general, which is something you don't find very often elsewhere.
There are two big bonuses of coming to this course. One of them is the access to the open experience with the cadavers as well as the simulators. And even though you could get that at almost any institution, to be surrounded with one-on-one with an instructor that's literally, sort of correcting you without any time constraints outside of the operating room environment, I think is really, really nice. And then the second thing is just the technological access in this particular training center is just, I've never seen anything like it.
Hello, my name is Ross Rule, cardiovascular and thoracic surgeon at Houston Methodist Hospital. Greetings from the Texas Medical Center. On behalf of the DeBakey Heart and Vascular Center, I welcome you to join us for the Cardiovascular Fellows Boot Camp. This will take place at the Houston Methodist Research Institute and the Hotel Zaza just down the street. This is a truly unique opportunity for first-year cardiac surgery fellows to have a crash course in cardiovascular medicine, cardiovascular and endovascular procedures, and invasive diagnostic and therapeutic technologies. This course has been described as Disney World for cardiovascular surgeons without all the lines. It is truly multidisciplinary, hands-on experience complemented by lectures, simulations, and a direct instruction from the basics to the newest innovations. This is an excellent introduction to transition fellows into the world of cardiovascular surgery, guided by world-class faculty. The full schedule of lectures, hands-on sessions, and events can be found on our website, along with complimentary registration, travel, and lodging. We are offering a stipend on a first-come, first-served basis for qualified attendees. We hope you'll join us, and we look forward to seeing you at boot camp in August in Houston.
Hello, I'm William Zogby, Chair of the Department of Cardiology at Houston Methodist Hospital. On behalf of the DeBakey Heart and Vascular Center, I invite you to join us for our annual Cardiovascular Fellows Boot Camp. This will take place at Houston Methodist Research Institute and the beautiful Hotel Zaza and the Texas Medical Center. This is a unique opportunity for first-year cardiology fellows, where you can dive into most areas of cardiology at the beginning of fellowship and learn about the basics and the latest developments in cardiovascular medicine. You will learn alongside first-year fellows in cardiac and vascular surgery and cardiovascular anesthesiology. Expert-led interactive lectures are complemented with hands-on training covering topics such as TEE and transthoracic using stimulators, hands-on management of cardiac emergencies, assist devices, vascular access, heart catheterization, and a guided tour of cardiac and vascular anatomy from a surgical point of view. We will provide you with a complimentary registration, lodging, and a stipend for travel on a first-come, first-served basis. The full program of lectures, hands-on sessions, and events will be available on our website. We hope you will join us, and we look forward to seeing you at boot camp in August.
thank you for doing such an amazing job.
Good afternoon, everybody. I'm Rusha Parikh. I'm one of the imaging fellows here at Houston Methodist, and I'll walk you through the case. So this first case, we have a 23-year-old woman with a history of asthma presenting to the ER with shortness of breath and chest tightness. She used some Duoneb at home with minimal improvement in symptoms, presents to the ER, and more description of her symptoms. They were sudden in onset. It started in the middle of the night and worse with deep breathing. History significant for allergies, penicillin, past medical history of asthma since childhood, and reflux. Past surgical history significant for laparoscopic sleeve gastrectomy. Past social history, never smoker, occasional social alcohol use, 1 to 2 drinks per month, no known recreational drug use. Home medications, a list of medications essentially for her asthma, including inhalers and omalizumab and a few vitamins. Review of systems as described before, positive for chest tightness and shortness of breath. Physical exam, her vitals were stable with a blood pressure of 114/56, heart rate of 88 per minute. Temperature 98.6 afebrile, respiratory rate 16 per minute, saturation 100% on room air, and otherwise nothing significant on physical exam. No murmurs, normal S1, S2, lungs were clear to auscultation bilaterally. This was her EKG, sinus rhythm with a PVC, and concern for Q waves in the inferior leads. And heart rate was 70 beats per minute. So in the ER, blood test came back positive for a troponin of 14 with the subsequent troponin of 7. White count normal, hemoglobin was on the lower side, concern for some anemia. A CT-PE was done with the chest pain positive troponin, and there was no evidence for acute pulmonary thromboembolism, no evidence of pneumonia. She subsequently underwent a transthoracic echo. Over here, we just have a preview of the echo and, sorry. So, let me see if, so parasternal long axis, again, it looked like normal function, no significant MR or AR. Here we have contrast images, which again just show that the EF was preserved. The estimated LVEF was 60 to 64%. RV size normal, RV systolic function normal. No wall motion abnormalities were noted. So she was subsequently referred for a CMR for a myocarditis evaluation, given her positive troponins, her chest pain, normal echo. And here we have our SSFP cine images. We have our stack of short axis going from the base to the apex. And then here we have our 4-chamber, 2-chamber, and 3-chamber views. And again, we can see here that the LV, Basil?
What I see, so I mean, I'm looking for overall LV systolic function, which looks preserved, looks within the normal range. I'm looking for wall motion abnormalities while you were talking. I don't see any obvious ones that struck me. We have, you know, all the walls represented also in long axes. And of course, you don't want to ignore the RVP. It looks like it's, you know, I want more RVPs, but it looks like normal systolic function. Can we go back to full screen? Okay, so you're looking for regional wall motion abnormalities. The other thing also can be helpful is to look for. Oh, sorry. The other thing that can also be helpful just on the cine images, if you're looking for myocarditis, is also to look for any areas where there's increased wall thickness, right? Because if you have myocarditis, what you're going to have is you're going to have an increase in edema and increased water content
in those areas, and that will lead to regional increases in wall thickness. Now, that's not a sensitive finding, but those are all the things that you'd want to look for. And so so when you scour through this, you would say you don't see any subtle wall motion abnormalities at all, or? Because again, what you're looking for is not kind of big glaring abnormalities, but small subtle abnormalities.
I think there is in the mid anterior septum, if you look at on the upper panel on the right, but I noticed at the mid septum, there's like this small segment that's not thickening as much as the base or the apex of the septum. That would be my observation. I don't know.
Is this what you're talking? Let me see if I can.
If you go to and if you go to the long axis on the third chamber,
Is it what?
in the in the mid septum, almost there. Yes, that's the one.
And again, you're not letting yourself get fooled by looking at wall motion. Rather, you're focusing on wall thickening, right? That's the key thing, because sometimes you can have translational motion. So I agree with you. That area, that's an area where I'd want to make sure I look carefully at the delayed enhancement in that location, because that's a subtle area where it does look like there may be a regional impairment in wall thickening. Okay. And just to go over how the EF was quantified, it was quantified again as lower limits of normal. So we had a normal EF and LV and RV, and the cavities were not dilated. Let's see.
So a very important point when you're looking at a very young patient who's presenting with a troponin spill of 14, you definitely want to focus on regional wall motion abnormalities, which are non-coronary distribution here. And I would say definitely when fellows are reading echoes, focus on subtle changes and coronary distribution wall motion too, and especially when and also look for pericarditis. So myopericarditis is a possible differential here. So you definitely want to look at that.
And another thing to note, both on CMR and echo, there was no pericardial effusion or pericardial thickening noted. So these are the T2 weighted images like we talked about before, where we're looking for edema in the myocardium. And again, there's no hyperintensity to suggest significant edema. So next we come to the late gadolinium enhancement images. This is single shot stack of short axis, 4-chamber, and 3-chamber. Does somebody want to go over what they see? And then I'll show you the high resolution images, which do show things better. Are you able to slow it down? Let's see. Should I just? Oh, yeah, that's fine. Yeah, so I have the high resolution delayed enhancement images.
Yeah. So I just want to make sure I'm looking at it before I see it. So where we were kind of looking earlier, well, first of all, I do see some late gadolinium enhancement. And to me, looking from base down to the apex, it looks like I see some in the anterior wall. If you look at the top left, yeah. And so just to refresh everyone's memory, I mean, normal myocardium is going to appear black, and anything that where the gadolinium is interspersed is going to appear bright. And the pattern, first of all, I want to see like how far down it goes. So I see it near the base, and I see it also in the anterolateral wall as well, from base even to the mid ventricle. And even it looks like all the way down to the apex. In the middle row to the right, I'm seeing some late gadolinium enhancement there. And the pattern, it does not look like an ischemic pattern, so it's not sub-endocardial, it looks sub-epicardial to me.
which is more consistent with a non-ischemic pattern, which in the differential diagnosis would include viral myocarditis, which we were suspecting. And so anytime I see it in the short axis, I want to confirm it in the long axis. And so if I'm looking at the 4-chamber view, and it does look like the basal to mid, mostly in the mid to apical anterolateral wall has that pattern, because you can sometimes be fooled. And it looks like I'm seeing a bit in the inferior wall as well on the 2-chamber view. And when I look at the short axis, it looks like it's there as well, from base to mid and even a little bit in the apical region.
Sorry.
Also subepicardial.
Right. So yeah. So both of it looks like anterior wall as well as inferior infralateral wall. And you can even see some at the RV insertion site. If you look at those two views right there. And again, all of these are epicardial-based patterns of enhancement. So again, this is not what you would expect with coronary artery disease,
Correct.
right? So this looks like a pattern that you would expect to see with non-ischemic myocardial injury.
And then just a 17-segment model of the scar. So we call the infarct size about 11%, all non-CAD epicardial pattern as we described, and mainly confined to the the lateral walls and the inferior walls, and almost sparing that area where we thought there was possibly a wall motion, but
It does affect the mid. If you look at the 4-chamber view, the mid-infraseptum, you can see a little bit on the. You can see a little bit on the RV side of the mid-infraseptum on the 4-chamber view.
yes, but not on the anteroseptum specifically.
Yeah, but again, this anteroseptal view, this 3-chamber view right here, that location is not the exact same
Okay.
as the sinuous.
So
before
yes.
we stop, why was the T2 weighted image did not appear to show any high signal intensity? Oh, it looks like a great image. No, the question was typically, and it's one of the Lake Lewis criteria for myocarditis is that you need, not one of the criteria, but why do you see absolutely no high signal intensity on the T2 weighted images?
So again, the edema, hyperemia are findings of early inflammation, and sometimes when it progresses more, it becomes homogeneous, and we might not identify it that well. And I'll leave it to Dr. Shah to answer.
Yeah, I mean, I think this is an area where there's some debate within the MRI community. One of the challenges you have is that the T2 weighted images, the quality of the images is not as high as your delayed enhancement images. And so that's why, I mean, what I really place most emphasis on is the delayed enhancement images. So yeah, this is kind of an area that's debated still actively within the community.
So the respiratory pathogen panel that is typically done here, testing for coronavirus, rhinovirus, influenza, parainfluenza, all came back negative. So for this patient in the hospital, her presenting lab was a troponin of 14, went to 7 for subsequent rise again at 15 and then 13. She was discharged at this point with the diagnosis of myocarditis with a plan for follow-up in clinic. And at that time, another echo was done, another troponin was done, which was at 7. She did come back for a follow-up CMR to assess what the scar burden to see if it had improved or it had progressed. And we still continue to see scar in all of the places we had seen it before. Anterior, lateral.
So the question, I guess, does the presence of persistent hyperenhancement, what does that mean? What's the time delay here between the initial scan and the follow-up scan?
So this was about 6 months later.
Okay. So does that mean that there's active myocarditis still ongoing?
No, this probably means there's been necrosis of the myocardium in the site where there was active myocarditis at some point.
Right. So I think the key thing is that wherever there's myocyte necrosis, myocytes don't regenerate themselves. So wherever you have an area of hyperenhancement, on subsequent follow-up imaging, that area will still hyperenhance. But as the edema resolves, the size of the hyperenhanced zone will get smaller, right? Now, if you had a very small little areas, it could get smaller to the point where it's below the resolution of your technique. So you may think, oh, it's gone, but in fact, it's not. That's not the case. So I don't think that from this you should infer that this is indicative of ongoing myocarditis. I think this is just indicative of kind of the normal convalescence.
Yes. And this is what we talked about, the updated Lake Louise criteria and how their CMR criteria for myocardial inflammation, where we look, the main criteria is looking for myocardial edema with T2 mapping or T2 weighted images. And then we look for non-ischemic myocardial injury with either an abnormal T1 ECV or LGE, which we typically do. And then there's supportive criteria of pericarditis, which we can review as effusion in the cine images or abnormal LGE, T2 or T1, and then systolic LV dysfunction with either regional or global wall motion abnormality. And then another interesting finding was patterns of myocardial damage in viral myocarditis, where they assessed the patients with who had concern for myocarditis, got contrast CMR images, and were subsequently diagnosed with the biopsy-proven myocarditis, and where they were able to differentiate the different viruses. So here they saw that parvovirus B19 and HHV6 were increasingly found in the endomyocardial biopsies, and parvovirus had a predisposition to affect the lateral walls versus HHV had a predisposition to affect the septal walls more. And we can see that reflected here, where parvovirus is more lateral and HHV is more septal, and there could be a mix of both. So CMR also gives us prognosis information. In acute cases, sometimes there is myocardial edema without LGE, and these cases, the patients have improved recovery and outcomes. And any questions?
Why do you think your troponin I was still persistently elevated if this was an ongoing viral myocarditis? Why do you think your troponin I was persistently elevated in the clinic 6 months later if this was an ongoing viral myocarditis?
So the first follow-up troponin was actually 2 weeks later when she came out for a post-discharge follow-up visit. So that could have just been the downtrending troponin from the 14.
Was there a follow-up at 6 months?
There was not a troponin follow-up at 6 months.
Okay.
Her symptoms had resolved by then. Hand it over to the next speaker, Dr. Califf.
Alrighty. Thank you, everyone. I think we'll be presenting an interesting case here where it may generate some interesting discussion. And most importantly, we're going to have a very sick patient. So this conference will also help us in the management. All right, a disclaimer before I start. The initial information is all based on chart review. The patient was referred to us as a tertiary referral center for valve patients. So a lot of it is extracted. This is a 69-year-old Hispanic female with history of rheumatic heart disease. She's had mitral stenosis with 2 repairs requiring commissurotomy in the past, the last one being in 1987. History of atrial flutter and fib, multiple ablations complicated by a high degree AV block, and now is pacemaker dependent. She was recently diagnosed by her treating cardiologist by hepatic congestion and was referred for hepatology for hepatic congestion, as I said. But she continues to have worsening lower extremity edema and fatigue. Her home medications are metoprolol 50 BID, furosemide 40 BID. She's on aldactone, atorvastatin, and warfarin. Family and social history is really non-contributory here. So as far as her physical exam, normotensive, pulses at 60. Generally, apparently she looked okay, lungs were okay. Her heart rhythm was regular rate and rhythm. There was a widely split S2, no S3 or S4. Apical impulse was non-displaced. A 3 out of 6 systolic murmur was heard at the third intercostal space with radiation to the neck. There were no diastolic murmurs, no JVP. Her legs were significantly swollen up to the thighs for plus pitting edema with brawny discoloration. I think we can move on, but the physical exam findings were not really consistent with mitral stenosis patients from what I'm seeing. I don't know if any of the other fellows would like to chime in on the the cardiac exam findings. Okay. It was called wide split. I don't know if anybody,
Was there S, did she have a prominent S2?
I am chart reviewing. I never laid hands on this
Because her exam
patient.
was mostly consistent with pulmonary hypertension and RV failure.
Correct.
So you really would think that this could be mitral stenosis and that her RV, significant, and her RV has taken a hit.
Correct. And she's also paced in a right bundle pattern or a left bundle pattern do give splitting of the second heart sounds too. Especially a right bundle will give you a wide split. That were documented. Alrighty. So again, this is a transthoracic report that was extracted. A preserved LV function. The RV is dilated with preserved function. Mitral stenosis is said to be moderate with a gradient of 7 at a heart rate of 60. There was aortic sclerosis, no stenosis, severe TR, and pulmonary hypertension. Would you like me to zoom? The systolic was reported at 37 on RA pressure of 20. And then if we do the math, I guess systolic pressure would be around 40, yes, with a 2.05. EF by fractional shortening is said to be 49, reported at 60. I don't know. So this is what we got. This is the patient that we have at hand. The patient was referred to us because the treating physician did not feel that the echo findings were congruent with the patient he's treating. So the patient was sent here for a TEE. Oh. Sorry. Here we go. All right. So let's pick one of our echo fellows who's in the lab. Anyone? Who's in the echo lab right now? Nobody's? Okay, Man, do you want to? Come on, Man. All right, what do you think, Man?
Could you play? The tricuspid annulus is significantly dilated. The mitral valve is stenosed, and We don't have a TR
Sorry, this is not looped.
jet here.
You think the RV is big?
Yes.
Okay.
There's a
I see a
pacing
pacemaker.
wire.
Okay. I'll give you some more images. Can you
There's a little
describe
bit
the
of-
mitral valve?
Moderately thickened, appears somewhat rheumatic, and I don't see the opening as much as I want to.
It's not really cooperating here either. Okay, let's do this. All right, mitral valve.
Yeah, there's significant restriction of opening. I can't really comment on the commissures though. And, you know, a 3D would be helpful here.
We'll get there. Okay, so
The TVI
gradients.
is quite elevated. I mean, suggestive of significant MS. Gradient here might be kind of, you know, it might give you the false impression that the MS is not as significant because of the relative bradycardia.
Okay.
But the TVI being 68 suggests significant MS, I think.
Again, more views.
No.
How does the aortic valve look? Yeah, we'll be discussing that pretty
Patient has
extensively.
significant RV dysfunction or significant tricuspid regurg, low flow, low gradient, similar to what we have in the aortic valve. There's a new concept came from the Mayo people, low flow, low gradient mitral stenosis. So
Yep.
gradients are very flow dependent.
Very true, and we'll talk about that more. Okay, aortic valve, little bit of stenosis. Again, rheumatic appearing aortic valve. Let's look at the tricuspid valve here. What do you think, Man? Does it look bad? Yeah. And this is.
The physical exam was falling apart.
All right. This is the 3D of the, oops. This is the 3D of the mitral valve. Okay. So what do we think of this before we see the final report? Just a general consensus, Non? What do you think?
I think anatomically and by the majority of the hemodynamics, there's severe MS, and like Mohammed is saying, you know, with significant reduced forward flow caused by the significant TR, you know, the mean gradient will be falsely lower, like Dr. Pasha said.
Okay. So this is the reporting of the TEE, where RV is severely enlarged. Function is lower limits of normal. RA, as we can tell, is enlarged 2. The aortic valve area is 1.5. The mitral valve was said to be moderately stenosed, again giving a gradient of 7 at a heart rate of 60.
It looks like a pinhole orifice, though.
Okay. No. So this patient, based on their congestive hepatopathy and whatnot, got referred to our surgeon for consideration of tricuspid valve repair. But I wanted to bring that point of what we define as mitral stenosis before we talk more about this patient. So traditionally, mild, moderate, and severe were thought to be defined with an area of greater than 1.5, 1 to 1.5, and less than 1, with some supportive finding from the pulmonary arterial pressures and the mean gradients. Moving forward to 2014, the guidelines changed to take into account a lot of these changes. Not everybody's fitting within those valve areas. So there is at risk for MS, progressive MS, asymptomatic severe MS, and severe symptomatic MS. And even in patients who are asymptomatic with severe MS, they're defined as a valve area of less than 1.5. Those with a less than 1 are defined to be a very severe, and there are various cutoffs that are taking into place. So I think we should all, like when we report our echoes, just keep in mind all of these new changes. So the surgeon saw our patient and they thought, well, something doesn't fit. Somebody examined the patient and a CMR was obtained.
What's the reason? I'm still not sure here why they're getting the CMR.
I think the reports are all saying moderate MS. The patient's looking really sick. There's something, as Man said, if we're putting the whole picture together, the patient's in low flow state. Yes, the mitral valve area is calculating 1.5, 1.6 on other reports, but everybody's labeling her as moderate mitral stenosis. Something's not fitting.
Because I mean, I guess the question would be is, if your question is assessment of severity of mitral stenosis, I'm not sure that CMR is the best test for that.
Agreed. And then the issue of the
I think, I mean, you're very right. What do you need to assess the severity of the mitral stenosis here? You see what I mean? What do you need, right? You have a mean gradient of 7 at the normal heart rate because it's paced. Pressure half time is unreliable. You look at the VTI, which is in the 60s. So if the stroke volume is 60 coming through the ventricle, which is small, you have a valve area of 1, right? You have wide open tricuspid regurg. You have a pacemaker through the tricuspid valve. I don't know if that's contributing, yes or no, right? You have a hemodynamic situation that is on the left side, low flow situation. So therefore, the mitral stenosis is severe. There's no question about it.
Yep.
And it looks like rheumatic etiology, right? Or at least, you know, there's some doming on it, rheumatic etiology. So this individual needs, you know, if you need something, all right, that is of concern, or what I need, if I need something, I need hemodynamics, okay? If I need something to tell me as to, and even then, I'm really not sure. And why? Because I'd like to know maybe the PCW on this individual. And is there some pulmonary venous hypertension that's because of chronic, you know, situation? You know you have a low flow in the pulmonary circulation, right? So your PA pressure may not tell you about pulmonary vascular resistance. And this is how you're going to think, because this is a low output situation to the left side, right?
Correct.
And so
LV
whoever ordered, I mean, I know the surgeons love to order MRI, and we love to order MRI. We have nothing against it. We love it, right? But the question is, you order it for something. There is a reason, not for mitral stenosis, but there is a reason. I cannot tell because of the first test, what additional information do I get, right? That is going to change my outlook, or, you know, I'm really not sure of what the situation. So I don't know what else are you going to, you're going to planimeter the mitral valve. You had a 3D you could planimeter it from. You're going to take a look at ventricular function, left and right. I think the images were pretty decent to do that. You understand what I mean? I just don't know, and you don't have hemodynamics. So I get the hemodynamics, right, and everything else from a structural point of view, and I fully agree with Deepan that, yes, you know, you are the stewards. I mean, it's love, you know, we love to talk about academics and understanding each one of them, but ultimately you are the stewards of a healthcare system, and you have to decide what test do you order, when and how, right? This is how you navigate it.
Yep. So I think we'll just go through the CMR images. I fully agree with Dr. Z. You know, we get a lot of these referrals, and sometimes it's very hard to convince ordering provider of, you know, this test might not be the best thing. So this was one case where we had to do it. Cine images, again, the RV is huge. Just what's really remarkable is on our 4-chamber, we see the mobility of the pacemaker leads with this regurgitant jet. So a component of the jet is just causing significant movement within the leads as well. Short axis showing you the aortic valve, thickened, stenosed, but not out of the ordinary, nothing severe here. The mitral valve, severely diseased, various cuts through it.
It's interesting to me that you have less artifact from the pacemaker here. Is this a usual thing, or do you have to use a special sequence?
We used a gradient sequence here.
Right.
Yeah. I mean, in general, the pacemakers don't really cause that much artifact. Yeah, so they're usually pretty. This is part. Yeah, this is kind of standard for pacemaker. Yeah, it's the ICDs, the high power leads that are bigger that will cause more of an artifact. And it's usually the generator itself that's causing the bulk of the artifact.
So based on the chest x-ray, the lead, actually the pacemaker box was quite lateral, so this one was pretty good. We didn't see any delayed enhancement. What's really impressive here, we talk about hepatic reflux. So this is our arterial phase. So technically our venous system should not be pacified, but we can see the IVC, the contrast in it is equally as bright as into the aorta. So, okay.
Could you relay the physical findings to whoever examined her? All right. I mean, really, I mean, this is an individual where you have regurgitant, V wave, if you call them. I mean, unless you're not seeing anything, the neck is very difficult to examine. You're going to have collapsing, jugular veins here.
Yeah, for sure. Okay.
And a pulsatile liver, right? I mean, this is how you're going to examine somebody. You have to kind of put it together with a clinical situation.
True.
Because if you tell me somebody with mitral stenosis has only leg edema with brown edema and everything else is fine, then your differential is very different.
Yep. All right. This is just a basic overview of how we use CMR for volumetric quantification. We do short axis slices through the ventricles. We define end systole and end diastole. We know the area and the thickness of each slice to calculate the volume. And based on the differences in the volume in end diastole and end systole, we define a stroke volume. Then we prescribe a slice through the velocity encoding phase sequences that we have to define the amount of flow through whichever, whether it is a valve or a structure that we want. So in this case, all right, CMR short axis slices, we're getting a RV end diastolic volume of 440 and RV forward or a stroke volume of 218 contrasted to the stroke volume on the left of 58 with an EF that's preserved on the left and low normal on the right.
So if your stroke volume systemic is 58, right, Man? You got it, right? The area of the mitral valve, right, which is your stroke volume divided by a VTI of 68, is less than 1.
Correct.
Now you wonder, and I don't know, all right? I doubt it, but you wonder whether in lower flow mitral stenosis, you have an over-exaggeration of a lower valve area, similar to an aortic stenosis. I doubt it, though, because there's always a gradient that opens up this valve. And you understand what I'm talking about? Is there any flow dependency of the opening, right? And I don't know that. I think the only way you're going to know that if you do a little experiment by stressing somebody and taking a look at flow situation, what the flow is. I mean, we could do that here, right? And see what happens to gradients, what happened to the ratio of VTI to gradient, something like this.
Okay. So in this case, the forward flow through the pulmonic valve came out to be 37 cc's. And the stroke volume that the RV is trying to eject during systole is 218. So the regurgitant tricuspid volume is 218 minus 37. That comes out to 180 cc's going back to the liver and the venous system with a regurgitant fraction of 83. So we talk about cutting severities or various cut points with Dr. Zan for severe TR. I think this is way past it. This is by all means torrential TR. So
the question is, how accurate is 37 cc's of PA flow? And you're going to have to tell us what's the difference between 37 and 58.
So as far as 58, so we did get our aortic flows. There was no significant aortic flows. There was a little bit of MR2. So if we do the calculations correctly, I think the 37 is fairly accurate the amount that the aorta is also seeing is similar. There was no AI to explain a difference between the AO.
So, yeah, so in this case, so I think the point Sharif is asking, which is a valid point, is you've got an ICD or you've got a pacemaker lead in the right side. So you're measuring flows in the pulmonary arteries that's distal to where there's metallic objects. So the question is, can you get an error in the measurement of your PA flow?
We
And
can.
so that's why usually what you're going to do is also look at the aortic flow, which shouldn't be affected at all by device issues. So the question is, if your PA flow and your aortic flow match, then you can feel pretty confident that your PA flow measurement here is correct. If they don't match, then I would actually use the aortic flow as my measure of what my systemic flow is, instead of using the PA flow. Well, no, because the blood flow is going through the right ventricle into the PA, and you've got a device lead sitting in the right ventricle. So that can cause a little bit of dephasing of protons, right? So again, usually it's more of an issue with ICDs where you got bigger leads than it is with pacemakers. But theoretically, if you're measuring something distal to where there's metal, you can always get some dephasing and you get some loss of volume or loss of measured volume. So that's why you always do the secondary check. And in this case, you said
The aorta wasn't much different.
aortic flow was similar. So then that's how you know that your PA flow is correct. I'm sorry, say it again.
That was the stroke
no.
volume through the LV
LV.
stroke volume, not through the aorta.
Right. Unless there's mitral regurg.
There is mitral.
Unless there's mitral regurg. Unless there's mitral regurgitation.
There was mild AI and mild MR. Yeah. Yeah.
Well, I guess, how do you define the absence of any real regurgitation? Yeah. Yeah, so
And I come up, say, with 65 cc's. And I can measure mitral inflow volume, and I can come up with 55 cc's. That's acceptable because of the errors that we
so usually
encounter.
what we kind of think of is the maximum error should be about 10 cc's.
Okay.
Right? So if you start to get more than a 10 cc difference, let's say between your aortic flow and your PA flow, then you worry, okay, there's a discrepancy. But up to 10 cc's probably could be, the normal variability.
So about 8 to 10%.
Yeah, I guess it depends on the flow state, but yeah, probably 5 to 10%.
Okay, so putting the picture together, we believe the TR is torrential, severe. The mitral valve is significantly diseased. We called it moderate to severe. And the aortic valve was not much of a problem here. So putting this picture all together, I think this patient, sorry, there is a significant delay between. We'll make sure. Can somebody from IT move to the next? It's not letting me. I'm stuck. So I think this case brings the point of this notion of low flow, low gradient mitral stenosis. It is quite impressive in this case. This patient's been living with this moderate mitral stenosis diagnosis. However, truly, in fact, the RV is, so far the EF is okay, but everything else is showing us that this patient is in trouble and she is severely diseased. She has significant sequela of her mitral stenosis. The recent paper that Dr. Shamsi brought forward, I have included in some of my slides. I guess it's not showing up, but the Mayo Clinic Experience, they published a paper about 3 weeks ago now, the AHA journal, that shows that in 100 patients, they defined low gradient, low flow mitral stenosis in these patients who have a gradient of less than 10 millimeters of mercury and a valve area in the 1.5 or less range. And they followed these patients over time, and they saw in their experience that those patients with low gradient MS, actually, even if they intervened on them, those patients did not do well over time. They symptomatically did not benefit from the procedure, and this has a couple of components to it, and they actually had higher death rates as well. When we put this picture together, the patient was actually presented in valve conference, and the discussion between our valve team and the surgeons is to try to do a percutaneous tricuspid procedure on this patient. However, it's going to be super high risk. If we're increasing the stroke volume that's going, so this patient has a very low LV preload state. If we increase the LV preload or LA and LV preload here, this patient's going to, I don't know what's going to happen, but my gut is telling me the patient's going to not do
Go
too
into
good.
pulmonary edema. This
Yeah.
is what you would do, because the mitral valve stays obstructed, and you will sort of now send more flow through the PA. Why not do the valvuloplasty first for the mitral valve and then deal with the tricuspid?
Exactly. So I think, she's very tricky. She's in a tough spot, but whatever we need to do, we need to try to help her, because I think with just a simple tricuspid repair, we might harm.
You cannot do a simple tricuspid valve repair. You would do it only if you don't have any issues on the left side.
Correct.
So it's either you're going to do a percutaneous procedure if the patient is actually is a decent surgical candidate. I can't recall what the risk is. Then you do a mitral valve repair and a tricuspid valve repair, and think of doing something maybe epicardial for her pacemaker. Because ultimately that's part of the issue of tricuspid valve regurgitation. So, you have to think about all this, but a tricuspid valve, addressing it either surgically or even percutaneously is not the answer.
So this is what I have. Thank you. Do you want to? Do you have this here?
We have more?
Thank you.
All right, thank you so much for joining us. I'm Misha Nareskin, one of the General Fellows. So today I'm gonna draw a picture of a 39-year-old male. By his early age, he was already pretty sick. He had end-stage renal disease on dialysis. He had a history of hepatitis C, which got treated. He got a history of IV opioid use and currently on methadone and anemia of chronic disease. So he presented to the emergency department with shortness of breath, which was gradually progressing, mainly initially with exhaustion. On admission, it was basically with rest, was associated with chills, some infectious-like symptoms, but otherwise no chest pain, no palpitations, no significant GI symptom except occasional diarrhea. His home medication included valsartan, propranolol, and methadone. And on physical exam in the emergency department, he was oral normotensive, borderline tachycardic, tachypneic with O2 sats on 94%, on room air, febrile. But other than that, anicteric, he had a slightly elevated JVD. Lung exam was notable for diffuse crackles and presence of dialysis catheter in his right side. And heart exam was notable for 2 out of 6 holosystolic murmur on the left side, likely consistent with tricuspid regurgitation. And other than that, no neuroskin images. So his labs on admission were notable for profound anemia, hemoglobin at 4. Other than that, his white blood cells were just borderline elevated. And remember, he's end-stage renal disease patient, so his electrolyte disturbances are sort of chronic for him. Chest X-ray on admission, you can see there is a diffuse pulmonary congestion with areas of ground glass opacities versus consolidations in the right upper, right middle, and right lower, as well as left upper lobes. The right side of the heart is a little bit enlarged, I would say. It's more than 2 centimeters from the sternum. And the dialysis catheter is in place with the tip at the SVC or RA. And overall picture of this young man with shortness of breath, there were several reasons for him to be short of breath. First of all, he was profoundly anemic, but other than that, chest X-ray, there was a pulmonary congestion, not clear if he had a component of heart failure, plus those consolidations in many lobes were suspicious for like a diffuse pneumonia. So this was the echocardiogram, which was done on the day of admission. This view will represent the overall function of the heart. And as you can see, the size of the heart is overall normal, but the wall motion is diffusely mildly hypokinetic with ejection fraction in mid 40%. Left atrium, right atrium a little bit enlarged. The right side of the heart is overall normal size, and there is a small non-significant pericardial effusion present. And walking through the valves and valve function, obviously looking for some masses or vegetation is the reason for those consolidations in the lungs. The mitral valve is overall normally looking, not really thickened. There is only mild mitral regurgitation. The LVOT flow is preserved with that TVI. Pulmonic valve looks normal. Aortic valve on the short axis, overall not thickened, no suspicious masses seen, and tricuspid valve is also not thickened, overall normal looking valve. So despite besides the mildly abnormal ejection fraction, this echo didn't really raise any suspicion or concerns. And 48 hours after the admission, blood cultures of the patient grew 4 out of 4 Staph aureus. So decision was made to proceed with the TEE, looking for the endocarditis. And again, these views are looking at the mitral valve on the transvaseal 4 and 2 chamber. Again, mitral valve doesn't look thickened. There are no suspicious masses. No significant regurgitation, mainly mild regurgitation seen on the mitral valve. The aortic valve on the short axis also trileaflet, not thickened. So far, no masses seen. LVOT view, also normal appearance of the aortic valve with no significant regurgitation there. However, on the right side, which we can see, pulmonic valve is overall well seen and no significant abnormalities seen on the pulmonic valve, but the tricuspid valve looks a little bit abnormal. Mainly the septal leaflet of the tricuspid valve looks what is called like a windsock, a little bit tilted toward the atrium. We'll focus on the tricuspid valve in just a few seconds. Bicaval view showed the tip of the dialysis catheter and this large echogenic mass attached to the tip of the dialysis catheter, which is seen on many projections. The size of the mass is about 2 by 2.5 centimeters, which was in this clinical scenario representative of large vegetation. But seeing just the mass and sort of the elephant on this study, the imagers didn't stop and proceed with further investigation of that finding with the tricuspid valve, which they saw, and did more focused interrogation of the tricuspid valve, and confirmed this windsock appearance of the tricuspid valve, of the septal leaflet of the tricuspid valve, which usually represents some underlying flow in the interventricular septum. So they interrogated the interventricular septum with Doppler, color Doppler, but no significant flow they saw. So with this, the study was done, but however, due to disappearance of windsock appearance of the septal leaflet of the tricuspid valve, the presence of undetected intraventricular septal defect couldn't be ruled out. So the further workup was warranted. And mhm.
All right, if you're doing the transesophageal echocardiogram and if you're doing a transesophageal echocardiogram and you saw this, right? To help you in the differential of what you're looking at, what would you do? No, I mean, fine. Because I don't think a stethoscope would help me here, because once you put color Doppler, you don't see a high velocity jet. So you know you're not going to hear anything from a stethoscope point of view. So what would be a test that you would do right there to help you identify what the differential, I'm not telling you what the differential diagnosis in my mind, but what is the I mean, how would you do something to help you? Because it's crucial. Yes. Salient contrast doesn't have to be anything else. Salient contrast. Why? Because if this is a deformation of the tricuspid septal leaflet that is like, you know, wrinkled and pushed back into the left atrium and the right atrium, it's going to fill with contrast. If it is on the left side, coming into protruding either a sinus of Valsalva aneurysm, you know, which is, you know, it happens in those situations, or a septum that is, you know, whatever it is, infected, and communicating with the left side, then you won't see it.
Or you might see negative contrast if it's like a Gerbotti defect. If it's like a Gerbotti defect, you might actually see negative contrast into that little saccular space.
Yeah, but there is no jet. You see, I mean, there's no high velocity jet here.
Yeah, it wouldn't be high velocity. You're right.
I mean,
if that thing didn't, if it didn't
which is
fill, you'd be
event
suspicious.
LV to RA, would have a VSD-like jet, right? And I'm not, color Doppler tells me a lot, meaning there may be some flow there, but it's certainly not high velocity, at least to tell us that there is a ventricular issue. I still don't know where it is at, right? But
we had thought that the jet was due to a quite eccentric TR. We
yeah,
did,
and it would fill. I mean, it would fill with contrast if you did it.
I guess with the history, you are really concerned that there is a Gerbotti defect, though. Not, you know, and you would want to go on to get a CTA to confirm.
Almost always when you see this tricuspid valve kind of adhesive to the septum, people with membranous VSDs, this is how they spontaneously close. The septal tricuspid valve starts to adhere with age to the septum, and then it becomes kind of almost like adherent to the septum. And sometimes, whenever you're seeing this concomitant bulge, I think what Dr. Kumar said, you really want to rule out a defect, which I think probably the saline would have.
The interesting thing on your left lower screen, right? This is a base, a cut close to the base of the heart. And why do I know that? Because I see the coronary sinus, right? So it is not close to the membranous septum anymore. We're down close to the crux of the heart. And we're still seeing the abnormality, right? So, and it could be still affecting and eating up through the tricuspid valve. I just don't know at this stage of the game.
All right, so this T raised all the same questions in the lab when we were reviewing that. So the further investigation, as I've said, to rule out either IV intraventricular septal defect or connection between LV and RA. So the CT came to help, and this patient was scanned prospectively, and these are two images representing.
Can I ask why you chose CT in this case? I mean, I guess to investigate something like this further, you've got two options, really,
Right.
CT or CMR. And so in this case, what was the rationale for choosing a CT?
To basically to see the size, and second to assess the coronary anatomy for this patient. So outside of the septal defect,
Okay,
the
because
clinical.
I mean, I think CTs is a dialysis
and plus
patient, right? So that's what I mean. So I think those are important things. If you've got a patient who's on dialysis, we're not going to be able to give contrast when you do the CMR. So that's going to limit you a little bit. The advantages of the CMR would be that you can do some hemodynamic assessment as far as the magnitude of the shunt, if there is any.
Right.
But in this case, especially if you wanted to look at the coronaries without having to worry about the dye, then it could make sense to do a CMR, to do a CT.
Right. So on the left screen, we see sort of modified four-chamber U, and with the right ventricle on the left side, left ventricle, LVOT, aorta, and this is the catheter and the contrast field in the right atrium. And there is a intraventricular septal defect in the sort of proximal LVOT connecting the LVOT with the right ventricle, and this this structure is basically that windsock leaflet which we see on the echo. On the right, we see sort of modified four-chamber cut with the right atrium, right ventricle, and LVOT cut, and we still see this intraventricular septal defect. We did a, I'm sorry, apologies. The cine image, it was scanned prospectively, and there are basically only 4 time points, but you can still see contrast flowing from the left side to the right side, and the tricuspid valve moving and sort of tilting towards the atrium. And when we compare,
What gets me concerned when you do CTA, right? And it's hard to see flow because flow is everywhere, right? I mean, let's be critical here, right? So it's hard to see flow because you're not looking at flow coming in, and you don't have any more flow on the right side, and then left side contrast comes on board, and I can see flow. Everything is white, right? Unless I see a jet it would be hard to convince. You're inferring, right, that because of a communication that there is flow coming in and out. But I could tell you from color Doppler alone that you don't have, I mean, you have a VSD or a pseudoaneurysm, right? But you don't have flow neither to the left and right atrium nor to the right ventricle, right? And that's why I would have used contrast to see where is this at. If it was negative, I know it is coming from the left side somewhere, right? But I won't know exactly where it's starting.
Right. To the contrary, this CT scan was timed so the most opacification is coming to the left side, so the contrast is on the left side when we scan the patient. So the contrast is on the right side should be much, much less.
I know, but I see a lot.
Right, but when we see that on the like CT screens, we can see that there is actually like a streak of contrast going from left side to the right side with a, yes. So, but yes, and these are actually exactly 2 sort of planes on CT and on the TAE representing the same area, and still we can't really see the flow on the TAE images. And but radiographically, it was hard to distinguish. Is it just pre-existing membranous IV septal defect, which patient had for his whole life, or it's a new sort of infectious process? So clinical decision was made to watch him on antibiotics for a couple of weeks and re-image that. And currently, patient is in this 2-week window, so more images coming. But after we did that CT and identified that defect, we went back and tried to do a sweep images of the patient with echo, trying to catch that flow. And there were much more images than this, but with sweep imaging of the aortic valve and LVOT, we were still not able to pick up this small jet. Huh?
My 2 arguments
Yes.
against the CT diagnosis is if the membranous septum is very aneurysmal, how do you know?
If the membranous septum is aneurysmal, how do you know that the shot that you're seeing is not the membranous septum kind of doing this, and that it's just an aneurysmal septum rather than an actual perforation? And the second thing is, if the LV pressure is 100 and that the RV pressure is 40 tops, I mean, it's going to alias by color Doppler. That's why I'm still so
Remember,
confused
if
about
you
this.
have what looks like a pouch or a pseudoaneurysm from a chamber that doesn't communicate with another chamber, it's not a pass-through going somewhere else. The pressure is identical to your major chamber. So in this situation, the pressure is identical to the LV. Now you may see if this pouch empties, all right, like a pseudoaneurysm of the mitral aortic interfibril fibrosa, then it fills again with a little tiny jet that is not high velocity, and then it's just for a few milliseconds and will stop. Okay? In this situation, since it's not emptying, this diastole and systole are about the same, you may see a little tiny flow and very low velocity. Very low velocity because they are equal pressure. So this tiny chamber has the same pressure as LV. Okay? Be it in the LV alpha tract or a little down, whatever it is. So it is high pressure. And that's why you're not seeing any color Doppler, which is, you may see a little nudge, which is very brief usually, right? So, and by contrast, your CTA, once it fills, it's filled. You may have a little trickle, a little swirl in it or something like that, but that's about it, right? Now, where the impressive thing occurs, if this ruptures somewhere. If this ruptures into the right atrium or the right ventricle, you're going to have physiology like a ventricular septal defect with, with high velocity and everything else that comes with it, a murmur and everything else. That's why you're not going to hear anything here, right? And I feel also that the location is maybe a little further down. I'm not sure I think most likely this is acquired, and we'll see what happens. I think the worst that can happen in this patient is this ruptures. You'll hear a murmur, so I think you as a clinician, when you listen to them, every day, you're gonna listen for a new murmur, and then you have to address it.
Right. All right, and as is on our favorite show, not always our favorite hero is the king.
Where's my Marion?
All right, thank you so much.
That crown has tilted.
Exactly.
And the color is not as gold as that.